Is there a list of risk factors for delirium?
Yes, of course. With all these conditions, there's a very long list, isn't there? But of course, I'll name some of the ones that are more common, if you like, or more likely. See, as I said earlier, older age is probably the greatest risk factor, and there are many contributing factors. Not least because we think our blood-brain barrier, gets less, has less integrity within older age. And so noxious substances are much more likely to penetrate the brain the older we are. So older age is a risk factor. Severe infection is a risk. And sepsis and septic shock can often present with delirium. There's a bit of a confusion in the language, in that some of the sepsis language calls it encephalopathy. But actually, there's a lot of overlap between both. Other risk factors are substance, alcohol abuse, not abuse, sorry, that's wrong, alcohol dependency. And patients who are alcohol dependent and come into the ICU and develop delirium are much more challenging to treat. Other risk factors can be a genetic predisposition to dementia, or patients who are on the pathway to developing dementia. That, as I said, they may be attending a memory clinic, just have some problems in memory. And again, ischemic heart disease. Delirium is very common on cardiothoracic wards in cardiac areas. And of course, we think that's because part of the challenge in delirium is, built on atherosclerosis in our vessels in our brain and neuroinflammation, associated neuroinflammation. Interestingly, treatments like statins we think they'd work, and instinctively we think they work, but the evidence is still lacking.
That's very helpful. Now, the obvious question for a pharmacist, can drugs cause delirium?
Absolutely. And in fact, a lot of literature over the past 10 years is focused on drugs that cause delirium, not just in the intensive care, I have to say. In fact, on social media, I've seen a couple of colleagues recently, a number of drugs have what's called an anticholinergic burden. And in simplest terms, the higher the anticholinergic burden, the greater the risk of delirium, constipation, confusion, falls. And actually, if you expose yourself to these drugs for long periods of time, you can actually develop dementia. The most well-known drugs are oxybutynin and solifenacin, which are available for urinary incontinence. And actually, in fact, I was chatting to one of my friends who's a GP recently, and she said, well, it's great. The thing is, we get these warnings about this anticholinergic burden, and we know these patients shouldn't be on these drugs. But actually, if you're on a diuretic, the patients refuse to stop them because they find that the control of their continence is very important for their life. But the thing about the anticholinergic burden is I've named drugs here that have a very high risk. What will often happen is patients are on a number of medicines that have a low risk, added together as a high risk. And that's why polypharmacy in the elderly increases massively this anticholinergic burden. So that reducing the anticholinergic burden reduces the risk of delirium. And you may see in the acute setting patients coming in having had falls or complaining of constipation. In fact, I work partly on a neuro ICU, and I've seen some patients recently coming with subdural hematomas, which are, as a consequence of quite drastic falls. And they've been on drugs, 3 or 4 drugs with this high anticholinergic burden. This is more of a risk for our older patients. And we think this is again because of the blood-brain barrier being less intact. So the risk is higher as you get lower. Classic drugs, of course, are like those, like Nitol, I think it's diphenhydramine, is it promethazine? Yeah, and they have a massive anticholinergic burden. So they're great in the short term, they help us sleep, but in the longer term, in the elderly patients, they are a risk.
So just to be clear, this is not drugs which are being used as anticholinergics, but drugs which have anticholinergic effects as a side effect, perhaps.
Absolutely right. So, and these anticholinergic first effects are not immediately noticeable. A very recent one I noticed was olanzapine, actually. And in fact, people listening to this who work in ICU will recognise that actually we use low-dose olanzapine to treat delirium. In actual fact, it actually has a reasonable anticholinergic burden. So there's not much evidence that actually helps delirium, but there's even more evidence showing now that it harms it, or not harms it, but may trigger it. So this anticholinergic burden, there's going to be more and more coming out of it, but it's important to keep our patients informed of this risk and burden. And another group of drugs that you'll see this in is compound analgesics, cocodamol, with high amounts of codeine in elderly patients on their own is probably fine, but add that to oxybutynin or promethazine, that's a very high anticholinergic burden, and that will massively increase the risk of confusion, delirium, falls. These are the central effects. The peripheral effects are things like constipation, reduction in GI motility, and problems in urinary incontinence, of course, which is one part of the treatment. Urinary retention goes the other way.